and healthcare. We have experienced unprecedented time of rapid implementation of electronic medical records and other health information technologies. But now is the time to focus on patient engagement, patient safety, quality of care, and how we can prevent unintended consequences and realize the value of digital information. So it is our hope that today, with this exciting forum, we will be able to provide you and your colleagues the opportunity to share cutting-edge ideas that can make a difference. We have a great program planned for today, and I want to thank those of you who made this possible, our community partners and leaders in the region who dedicated their time to plan this wonderful event. I want to introduce to all of you the planning committee of this time, and please stand as you are introduced. Roxanne Beckham, University of Southern Indiana. Jeannie Brown, St. Mary's Medical Center. John Fedor Bessemir, University of Evansville. Who's John? Chris Fuller, St. Vincent Carmel Hospital. She's unable to be here today. Dr. Darla Grossman, St. Mary's Medical Center. Karen Jones, University of Southern Indiana. Thank you. Dr. Elizabeth Kalb, Indiana University School of Medicine, Evansville. And we have medical students here, and thank you so much to Dr. Kalb for bringing her students here with us today. Dr. Brian McGuire, University of Southern Indiana. Ruth, is Brian here? No. Ruth Metzger, University of Southern Indiana. Catherine Starnes-Keeley, Ivy Tech Community College. Dr. Kevin Valadares, University of Southern Indiana. Andrew Van Zee, State of Indiana Healthcare Strategy and Technology. He's unable to be here, ICD-10. Susie Vaughn, Community Health Network. She will be here probably in the next few minutes. Mike Wade, Deaconess Health System. Thank you, Mike. Beverly Walton, Community Patient Safety Coalition of Southern Indiana, Kentucky. She's unable to be here today due to illness. Thank you, Beverly. Dr. Frank Ward, University of Southern Indiana. Dr. Ann White, the Dean of the College of Nursing and Health Professions at the University of Southern Indiana. She is not here with us today, but I just want to say that she is the person behind all of this movement with health informatics in the tri-state area. And without her encouragement, and without her financial support, we will not be able to offer this event. So thank you so much to our Dean, Dr. White. And last but not least, I want to thank Peggy. Peggy's here. And her team, her wonderful team, they worked endless hours to make sure that this event is pulled off seamlessly and according to our crazy timeline, as usual. So we are truly lucky to have Peggy and her team at USI. Thank you, Peggy. Now, before I turn over the podium to Peggy, I just want to say that with such a large number of participants, and I'm sure people are still coming, so this will get even better, we are certain that this summit will be memorable, highly educational, and a not-to-be-missed event. So you come back next year. We truly value your participation and support. We are very excited to have you here with us. Thank you so much for coming, and I wish you an enjoyable day of learning and networking. Thank you so much. Now, Peggy.
Good morning. It's really good to see some new faces and the students that are in the audience, and I think we've got some residents here from Deaconess, and delighted to have you here, and I think there's some things on the agenda you'll really enjoy. and learn from. But anyway, I want to go through a few details to make sure you understand how to access the information, the handouts, and as well about and restrooms. So you should have received an email Monday and Tuesday going about the handouts and where to access them. It would have come from Jennifer Hurdle, and it was titled in bold, Important, USI Health Informatics. So if you're looking for the link, that's how you would get it. And that will give you a link to a web page with all the information. And it will also tell you how to get the free mobile app, which is USI Conferences, and you can download that. The directions for downloading that are also at the registration desk. So if you're having trouble getting connected, go there and see exactly how to do that. I bet our students are having no difficulty. It will be my age group that's having difficulty probably. But anyway, ask a friend or whatever. Since you've got your devices on, try and be sure they're muted because, you know, we're going to have them out all day. Has anybody having trouble signing on to the USI Wi-Fi? Okay, there's directions out there for that as well, and the username and password is HITSS, all lowercase, 2015. Username and password, same, okay? HITSS 2015. And it takes a while for our server to recognize that, so be patient as you go through and submit, and you have to wait a little bit for that to all connect. And then we're tweeting today, and you can tweet directly from the app, or if you tweet normally, and if you don't, here's your opportunity to learn something new, okay? And it's hashtag HITS15. Little variation on the username and password, but it's capital HITS15. So tweet a little bit, because we're trying to get some data about this. Gabriella may talk more about that later. Now, the important thing is everybody wants to know how to get their continuing education credits, and we require that you complete the online evaluation form within 2 weeks, which is like February or something. I can't remember what that date is. I think I've got it around somewhere. But anyway, pay attention to that, because your data is kind of lost to the summary of the data if you don't do that. And it just is really problematic if you come in later than that. So anyway, be sure you do that 2 weeks from today, and it'd be great if you could do it today. You can access that link through the app or online on the web link, either way you do it. When you get to the end of that, you're going to put in your data of your address and email, and you are going to tell us what kind of contact hours you want and how many sessions you attended. So all of that is required, or we're not going to be able to record you in our system that you've attended this. So be sure you complete that last piece. And you know, when you do that evaluation, let us know what you want to hear next year. That is really important to us about what things that we could do for the program in the future. So don't hesitate to tell us what you think. Now lunch, let's get on to that. The students who registered at a reduced rate got a meal ticket. And we are just a big group here at USI. There's a lot going on, and we grow, it seems, every year. So you will be able to use any venue in the university center to have lunch. And there's a sheet like this out there that goes through it. The app under announcements lists all those. So, choose where you want to eat. If you're new to USI, just ask us at the registration desk, or ask anybody here, what their recommendations are. But you're going to have 50 minutes for lunch, so you might want to spread out. There's lots of options. The folks that registered at the regular rate or the committee members and the speakers will be eating in the room directly behind us. And, we're 200 in number, and that only holds 90. So anyway, that's how we've solved that issue. So hopefully everybody will enjoy a lunch. And then we have exhibitors out in the hallway. We thank our partners today, which has been Deaconess and St. Mary's, and hymns and deaconess. So thank you for partnering with us on this. It's great. And Telemon is also exhibiting today, so you'll be able to see them. Okay. Any questions? Stop by the registration desk or stop me and enjoy the day.
Now, it is my pleasure to introduce our keynote speaker, Pat Masters. Pat Masters is among the nation's leading voices for patient engagement. She is president and co-founder of the Patient Voice Institute, patient co-chair of the National Quality Forum's Patient and Family Engagement Action Team, advisor to the Partnership for Patients, and author of the critically acclaimed book, Designed to Survive, 9 Ways an IKEA Approach Can Fix Healthcare and Save Lives. Now, if you haven't read the book, I highly recommend it. So you know what you have to do next. This is a book that looks at how simplicity, efficiencies, and partnership with customers can drive a better healthcare system. A career in news and the medical reporter, Pat's focus turned to patient advocacy following the death of her father from a hospital-acquired infection. She lobbied successfully to pass 2 Rhode Island patient safety laws and is the creator of a unique tool called the Patient Pod, designed to empower patients at the bedside with tools of engagement and partnership. In her presentation, Pat will speak on how human dignity and simplicity are often missing factors in the design of systems and tools for patients. She will explain how better outcomes also depend on patients themselves becoming the pull-through. Please welcome Pat Masters.
Good morning, everyone. Can you hear me? Is this mic on? Am I doing okay? So great to be here with you. 2015, a brand new year. Congratulations to USI for its 50th anniversary. And I came from the snowbound East Coast, very happy to make it here at the last flight, actually, into Evansville. So I hope you feel that it made a difference that I actually got on the flight. And 2015 has already started out with some good news for us consumers. You know, we've been struggling to get on our Wi-Fi today. I don't know about you, but I get really antsy if I can't be connected to my Wi-Fi and my devices. But we've already had a bit of good news in that sense, because I don't know if you caught this last week, but all the major hotel chains, Marriott, Starwood, Hilton, Hyatt, all announced in the last week or so that they're going to be offering free Wi-Fi in their hotels to their guests. I think this is such a victory. Can you hear me over there or just here? Because I wonder if is my mic on okay? Okay, it's just louder over here, so. So I think this is such a victory. Because doesn't it annoy you to pay a whole bunch of money for your hotel room and then have to pay an extra $15 or $20 for Wi-Fi? So I think this is a great victory for consumers. And you know what happens is that one chain reviewed the statistics that showed that in a survey, 35% of people said that free Wi-Fi was the number one amenity that they would choose when looking for a hotel for business. And the other chains are like, well, I guess we have to do it too, because they have to stay competitive. And it's the same thing when one airline cuts the fares for our flights. One starts it, and the others follow suit to stay competitive. And when the first company comes out with a small SUV, and they sell like hotcakes, and then all the other companies send their engineers to the drawing board, say, well, we got to make one too, or they're going to lose out, right? And then we consumers, we go online and we do all the reviews on Kelley Blue Book and Edmunds.com and Consumer Reports, and we look up the ratings and the comments and the prices and the features, and we create, we find the product that works for us. And pretty much competition not only keeps companies and businesses and industry on their toes, but it saves the day for consumers. Now, healthcare has always been different. For one thing, we can look at refrigerators and pretty much figure out what features we want and how much we're willing to pay for it. But, if we buy a washing machine that turns out to be a lemon, Maybe we're out a little money, and that's if the company won't give us satisfaction. Maybe a little annoyance, inconvenience. Maybe our underwear turns pink. But that's pretty much it. But in medical care, our lives can depend on our choices. And sometimes they're often completely in other people's hands. The stakes are as high as they get. And even when you work in the medical field, when you or your child or your mother or father or your friend end up in an emergency room miles from home, all of your power, money, insider knowledge, contacts, your influence, can all amount to a hill of beans in a place where nobody communicates, where staffing is short, where handoffs are sloppy, or you can't reach somebody who will listen. Unfortunately, this kind of thing happens too often, and it results in harm to patients too often. And we're going to look at some statistics on that in a bit that are scary but important to know. In the meantime, for physicians and nurses, patients, payers, and all of us, since all of us are probably going to be a patient at some point, the healthcare boat that we build is the one in which we must all float or sink. Now, some leaders and organizations are absolutely doing phenomenal work in this regard, and they're proving that excellence and safety at reasonable cost is attainable. My hope today is to inspire and challenge you to be part of a better version of American healthcare, one that you'll be proud to serve and also confident to receive. Now, one thing that will never change is that modern medicine gives us miracles. Do you know what that is up in that corner? I first saw this 10 years ago. They're growing human ears on the backs of mice. Think about that. A child born without an ear or an accident shaves off the outer ear. And it's something that, you feel you're not the same. They've actually implanted a scaffolding in the back of the mouse, and this tissue grows over it. Isn't that amazing? The middle. This is a 6-year-old boy who is throwing a football with a 3D printed prosthetic arm. It's astonishing. And over here, that man is kicking off the 2014 World Cup soccer tournament. He's a paraplegic. How can he do this? He's wearing an exoskeleton that he controls with his mind. Isn't this mind-blowing? Now, for me personally, I am no less impressed by medical miracles in my family. Surgery and care saved my brother from a diagnosis 4 years ago of bile duct cancer, for which he was given a maximum of 2 years. And he danced at his daughter's wedding a year and a half ago. Over here is my mother, 84 years old, still zipping around on her walker, playing bridge, living with stage 4 bone cancer because of the wonderful care and treatment that she's getting. And I am incredibly grateful. Now, if you had any medical training at all, have you heard of this, the triple aim of healthcare? I see a lot of heads nodding. How many of you have heard of the triple A? Triple aim. Triple A is for your car. Okay, the triple aim of healthcare. Now, this is a fine framework for understanding how we can be excellent in healthcare. It's like 3 legs of a stool. To truly reform healthcare and make it great, we've got to improve cost, the quality of care, and the experience of care. And so what does this mean? What does the triple aim mean if you're a patient? Well, let's look at a couple of patients. Here's my tale of 2 patients. Now, these could be your friends. As I look around the audience, it seems like they could be, somebody that you hang out with. On the left is then 24, well, actually, I want you to know that these 2 women happen to have been born 1 week apart in 1987, although they never did meet. On the left, we have 24-year-old Erica, a bright and compassionate woman who'd worked for 2 U.S. senators. She actually ran the travel arrangements for John McCain during his run for president. Can you imagine at 21 years old she was doing something like that? Very special girl. Well, 4 years ago, actually the Monday before Thanksgiving, Erica collapsed on the floor of her Washington, D.C. apartment, struggling for air. And she was rushed to the hospital where she was put on a ventilator. And Karen, her mother, recalls talking to the emergency room doctor who asked her, was Erica using birth control? And she said, yes, she is using a new device called the NuvaRing. And the doctor said, I thought so, because she's having a pulmonary embolism. And pulmonary embolisms, as you may know, are blood clots in the lung, and they're very, very dangerous. A couple of years later, Jess, on the right, a very adventurous young woman who had backpacked through India after graduating from college, and then hiked the entire Appalachian Trail from Georgia to Maine, which is 2,200 miles, suddenly felt this funny tingling in her hands and feet and some very bad pain in her back. And it wouldn't go away. In fact, over the next couple of days, it got intense and scary. And at the end of a few days, she really couldn't walk. So she was brought to the hospital where she was diagnosed with a rare nerve disorder. And it involves paralysis that moves from the hands and feet to the arms and legs. In 1/3 of patients, it reaches the chest, the torso. And what do you think happens then if your chest is paralyzed? You have to go on a ventilator in intensive care. And sometimes for months before this disease can be checked. And some of those patients, if you know what happens to a patient on a ventilator for a long time, some of them die. Now, Erica and Jess are just two of the 36 million people that go into the hospital in this country every year. Now imagine for a moment, this is, I don't know, your daughter, your sister, your friend. What happened to them? I'm going to tell you in a little bit. But I can tell you that these are just two stories that you will not hear about in any patient experience or patient satisfaction survey. Because the way we gather patient experiences in this country is inefficient and incomplete. You know, we talked about the triple aim, the experience of care. I won't go so far as to say that this system is antiquated and flawed, but the way we gather this experience information is designed to serve the needs of providers and not to keep a finger on the pulse of what really happens to patients and what they really care about. Now, I know a little bit about antiquated and flawed systems to gather consumer experiences because that's the way it's been done for decades in the world that I used to live in, the world of television news. Each day for more than 2 decades, it was my job as a TV news anchor to tell people the stories that I hoped that they would care about, that we as an organization would sit down and research and say, okay, let's do these stories today. And then the viewers would reward us by watching our station over the competition, which was also trying to do the same thing. This process was measured in ratings points that were gathered through statistical samplings of our viewers. And in fact, even today, although the Nielsen Company, which runs the system, has added the number of people to its sample than it did back then, presently they only use less than 20,000 viewers' habits to represent what all of us are watching on television. Now, this sampling, as I said, came from a service called the Nielsen Company, and they'd hook up a black box to your TV set, or they'd ask you to actually self-report in a handwritten diary, as you see right there. Every fraction of a ratings point would translate into advertising revenue, whether a show was canceled or renewed, and whether, of course, the anchors that delivered the news would get a raise or get the boot. Well, today in my former industry, I don't know about you, I haven't seen a commercial in months, except maybe when I'm in a hotel room and I can't record my shows, all right? And I see heads nodding. DVR recording lets me zip past commercials or watch a marathon of Breaking Bad episodes before the series finale. Networks are chasing a revenue ball that is shrinking and morphing as it bounces along. Many young people who've grown up with laptops in their hands instead of TV remote controls don't even own a TV. How many of you don't own a TV? And all of us are watching what we want, when we want, on the internet. Isn't that great? How much longer can the Nielsen Company stay relevant unless it changes a lot? And I tell you this because the industry struggles to capture patient experiences reflect what I've just described in the television world. The intent of these HCAP scores, have you heard of HCAP scores, those patient satisfaction surveys? Okay? They're surveys that hospital patients are asked to fill out after they're discharged. is to provide a standardized survey and collection tool to gather patients' perspectives on hospital care across all hospitals so they can compare apples to apples. And you may know some of these, the questions, but they're gathered actually by mail or by phone or by a combination of the two. And they ask patients to rate their communication with doctors, nurses, and about medicines, the responsiveness of staff, pain management, discharge information, how clean and quiet the hospital is, and the transition of care. It's administered up to 6 weeks after you're discharged, and the information comes back from less than 2% of people to whom it is sent, and up to 6 weeks after you have gone. And the feedback arrives 1 to 3 months after discharge. Now, this is capturing some data and some feedback from patients. As we've seen, not all that efficiently. What it is not capturing is outcomes. And which do you think matters more to the families of Erica and Jess? Let's look at what happened to them. And as we do, I invite you to think about your own medical experience or that of your friend or your parent or your neighbor, and whether that experience was solicited or recorded publicly in any database, any way that you can learn from it. Erica, admitted to the hospital with blood clots in her lungs, was declared brain dead 3 days later on Thanksgiving Day. Her heartbroken parents donated her organs, except for her lungs, which were choked with blood clots. What did Karen, her mom, learn from this after she lost her daughter? That the NuvaRing, the birth control that her daughter was using, has by some accounts a 56% and others a 90% increased chance of potentially fatal cardiovascular problems, like blood clots in the lungs. Now, some of your daughters and friends, maybe some of you, are using this today. Karen and her husband started a foundation to spread awareness of these risks, and they're lobbying the FDA and Congress to put stricter warnings on this device and to inform doctors. There was actually a big report in Vanity Fair about this, and the reporter sent 2 college-age women to 2 clinics in New York to see if, even after she described problems with heart disease in her family, they were asked if they were told that the NuvaRing was dangerous. In both cases, they got free samples and told not to worry. Free samples. So even the pharmacist that might have intervened and talked about the risks was not involved in that transaction. So you see how easy it is for this to happen to anybody. So as they struggle to go on without their daughter, what happened to Jess? Jess quickly got the right diagnosis of Guillain-Barré syndrome. It's 1 in 100,000 people. So it's often, because it's so rare, misdiagnosed as a pinched nerve or an infection. So that was already a victory, and she was actually being treated in the hospital that very same night. And doctors told Jess that in the very best case scenario, if she fully recovered, it would be 6 months to a year before she would be able to walk again normally. Her mother stayed glued to her bedside, scouring the internet for insights and information, researching foods and supplements to help support her treatment, working with the physical therapist, double-checking that medications and treatments were the right ones given at the right time, soothing her daughter's body, mind, and spirit. And in the end, it was not a year, it was not 6 months, it was not 5 months before Jess was walking normally again. But it was 10 weeks after her first symptom that her mother took this picture of Jess riding her bike, hands-free. Now, these stories have a few things in common. A terrifying medical emergency that came out of the blue. A mother who would have traded anything to trade places with her daughter. And in both cases, the best hospital care that modern medicine can provide. They also share the fact that no central system exists to capture Erica's and Jess's experiences, to learn from events that led to a tragic death in one case, and a recovery so incredible that a local reporter called it a miracle. Isn't that a sad waste of a resource for families and for science? Now, even if Erica had lived, the questions that HCAP's surveys ask would have missed the mark of what really mattered to her family. And Jess was simply so relieved to be riding her bike and living her life again. And when that survey arrived, weeks later, and then a pile of paperwork from the insurance company and other paperwork, she didn't want to go near it. It was either irrelevant to her at that point or a scary reminder of a dark time she was trying to get past. Now, in a world where with a click of a mouse, we can upvote a song on Spotify or like a post on Facebook or give 5 stars to a camera we bought on Amazon, can't we do better than that paper survey? Well, this is one reason that we formed the Patient Voice Institute, or PVI, to create this public platform. Like a TripAdvisor, unlike this, and unlike this paperwork, like a TripAdvisor for the patient experience. It's a go-to place where you can rate your experience, tell your story, and everyone can see it and learn from it. It's the wisdom of crowds, crowdsourcing responses, crowdsourcing the kind of thing we share at the water cooler or in the cafeteria or talking with our girlfriends or our friends at a restaurant. So that's a big, tall order. And some say, that can't be done. That can't be done. Well, they're already doing something very much like it in the UK, in the United Kingdom, where the rules are a little bit different, and the government says, yes, you'll do it because we say so. This site is called iwantgreatcare.org. I actually found this when I had a conversation with the CEO of TripAdvisor. He said, it sounds like you want to talk to Neil Bacon. Dr. Neil Bacon is a doctor who did this in the UK. So I had a phone call with him after I'd been through his website, and I invite you to check it out when you have time. And I said, this is fantastic. I would love to help, any way I can. If you're planning to come to the US, can we help you? What can we do? He said, well, he had a lovely British accent. I won't even try to replicate it. But he said, we have no plans to come to the US right now. We're going to South Africa, and we're going to the Middle East, but not the US. I said, can I ask why? Pushback from the industry. They're not ready. Well, we're trying it. We're just starting at the Patient Voice Institute, but we have seed funding to actually do something like this. So stay tuned as you check out our website. The new one coming soon. The second of the triple aims is cost. Now, U.S. healthcare, as you may know, is on target to cost nearly 20% of the gross domestic product in this country. That's $1 out of every 5 that is spent in this country. It's crazy. And our outcomes, as you may know, again in 2014, were last among 11 similar countries. And that was for the 5th time in the last 10 years, dead last. How can this happen? Well, these results come from the perfect design of the system we have. Because everybody is playing by the rules of the game, by the regulations and incentives that exist. They're very powerful special interests in healthcare, as you know, and this is how we've set it up. But new tools and technologies are changing these rules. And I want to show you a couple of things I think are very cool. Anybody heard of the Vscan? The Vscan is one of these devices. It's actually, as you can see, small enough to fit in your hand. Now, he's doing a full EKG of this patient right here using this Vscan. He does it in 2 minutes, and it costs nothing after the device is purchased, and it costs about $7,000. And that's as compared to it costing $500 per EKG. But of course, the doctor loses his fee in this model. So why aren't we using Vscans everywhere? We could save so much money. Well, I think I just said it. With 20 million echocardiograms done in this country every year, that's a lot of billions of dollars on the line. People want to protect it. Here's another big shakeup in the status quo. I don't know if you heard about this. This was on the cover of Fortune magazine. This system, the Theranos system, is revolutionizing how blood is drawn and tested. It's just incredible. Has anybody heard of this process? Okay. Between 40 and 60% of us, when we get an order to get a blood test from our doctor, we don't go. Half of us don't go. Maybe it's inconvenient. The lab is open 8 to 4, and we're busy. Maybe we're scared of needles. I know I'm a baby about getting my blood drawn from my arm. I don't like it. Maybe it's the cost. For some people, that copay or that, meeting your minimum for the year, it's just too much money. Whatever, people aren't doing it. Well, a Silicon Valley company called Theranos has created an entirely new way to run blood tests. And as you can see over there on the left, it uses as little as 1/100th of the amount of blood that's currently drawn for a blood test. From that tiny little amount of blood, they can do 70 different tests at a cost of 1/10 of what a hospital charges, and using 1/100th of the lab space. And, this is the crazy good part, it's coming to a Walgreens near you. They already have them in California and Arizona, and there are big plans to roll it out across the country. So you can imagine how that's going to shift our habits, the money. It's just one way this wave of change is just starting, and some people are seeing it and getting ahead of it. I just think this is terribly exciting, and because for one thing, it doesn't hurt. This picture right here, that woman getting her blood tested through a tiny little prick in the finger that's less than a diabetic's prick, from what I understand. I haven't had it done. That's the CEO of the company, 30 years old, Elizabeth Holmes. She dropped out of Stanford at age 19 and sat down across from her professor and said, let's start a company. And they started to work on this technology. So this technology is not just going to impact how blood is drawn. It's going to impact, she can look at a drop of blood and tell if you ate a cheeseburger or broccoli for lunch. So it's revolutionary stuff and fascinating to read about if you want to Google her later. I can't stop you from doing it now either. It's a free country. So here's a question. Why haven't consumers as a market force exerted more pull-through on this industry to contain these costs and improve quality? Well, it has a lot to do with third-party payers who sort of separated us from the pain of how crazy these expenses are. And why is that? Well, the disconnect also impacts the doctor-patient relationship. Because here's my metaphor for the ideal doctor-patient relationship. It's a tango dance. It's a fun, fun dance. But why am I showing you this picture? Well, it takes two to tango. And the ideal doctor-patient relationship looks a lot like a great tango dance in the sense that it's a really good balance of two respectful partners giving and taking. Sometimes one advances and the other, and then retreats. It goes around like a partnership. They give and they take. They fill in the gaps to help each other. They each step up to supply the best they've got. So nobody knows my body better than me. But I need the informed and trained mind to interpret what's going on with me and share decisions about what is the best path for me. Shared decision making, informed consent. Those are some of the terms that we're hearing a lot, and they happen all the time in an ideal world. This requires investment from both of the partners. Historically and culturally, though, until very recently, doctors have sort of been tangoing alone, pushing us around the dance floor. Take this, do that. We're going to do this procedure. And historically and culturally, we patients have been pretty okay with that. Give me a pill, sew me up, fix me, take it out of me. And somebody else is paying the bill anyway. That's a great over-exaggeration, but you get the point. There's been sort of a top-down way that we have been passive, and we have been happy with that role. But more and more, the patients who are content to be pushed around that dance floor are stepping up their engagement. And for one thing, of course, the reason is you all have one in front of you. The internet is letting us Google anything that we want to learn more about, any symptom, any treatment. We are going to be informed about that if we have any degree of capacity to care. But mostly, in terms of consumerism, when we start picking up that bill, you can bet that we start paying attention. Technology is changing the game too. Clear Health Costs is one such example. This is a website where if you need an MRI, a mammogram, your teeth filled, you can check out the prices at several cities around the country. A list of cities that's growing all the time. MediBid. Imagine this, you need a knee replacement and you live in Evansville, Indiana. But you can go online and find doctors willing to do that knee replacement in Boston. And there's a nice flight to Boston. The price is better, the doctor's the best in the country. So there's transparency allowing us to make these kinds of decisions. And when patients are given choices, just as we do in other parts of our lives, we choose more affordable. For instance, here's an example. Patients were asked, the patients using elective MRIs were informed of price differences among facilities, and they were asked to choose. And even though this was covered by Blue Cross and Blue Shield, they actually chose a cost reduction of $200 or nearly 19% per MRI. Now that's a decrease in the use of hospital-based facilities from 53% to 45% in 2012. Now, if you're a hospital, is that good news? It's pretty bad news. This is another sign that, gee, they're not going to be doing their blood draws at the hospital anymore. Now they're going to do less MRIs at the hospital. So you can see where this trend is going. So that's just one example. A Commonwealth, or actually this year in 2015, employers are going to pay over $5,100, employed people, for their employee copay and their out-of-pocket expenses. That's up 55% than they did in 2010. Out-of-pocket will have almost doubled since 2009 to almost $2,500. So we start to feel a pinch. It starts to hurt. We start to pay more attention. And a Commonwealth Fund report says almost half of insured low-income adults are skipping recommended treatments. They are non-adhering. Those bad patients, they're non-adhering because they can't afford the copays. So you don't have to be a healthcare futurist like Jeff Goldsmith to see that when people have major cost-sharing responsibilities, they shy away from using healthcare if they possibly can, and then they don't pay their medical bills when care use is unavoidable. Again, what's this going to do to the hospital model? So you're seeing big change. Do you see where it's going? Well, the CEO of Aetna does. Mark Bertolini says, as consumers become the principal buyers of care, true reform will take place. And with patients in charge of healthcare spending, much of the $800 billion, with a B, dollars, misused in various segments of healthcare would be saved. And when we say saved, of course, where does that money go? It goes elsewhere. It gets spent on something else. Maybe better healthcare, maybe education. We would have the choice. And says he, that much of this entails using technology to empower the consumer. It's the new model, and it's the only model that works. So we've seen how patients using technologies can redefine how patients share their experiences and are helping to drive down costs. How are we doing with the third leg of the triple aim? Which is quality. Well, we have a long way to go. Hospital medical errors are now the third leading cause of death in this country. Inadvertent medical harm. In 2013, an article was published in the Journal of Patient Safety that used something called the trigger tool, and they found that it could be as many as 440,000 deaths per year in the hospital from unintended medical error. And according to the CDC, that makes it the third leading cause of death behind heart disease and cancer. So this is just in hospitals, by the way. You may have heard, Joan Rivers' case. That was in an endoscopy suite that she died, but things like that aren't even counted. So this is a scary figure. And these numbers, by the way, are dramatically higher than numbers that were used for more than a decade in the 1999 Institute of Medicine report, To Err is Human. And that estimated that up to 98,000 people a year die of hospital mistakes. That's a bad enough number, right? But the new numbers are more than 4 times that number. And the Partnership for Patients says it's brought down some, 30-day readmissions, and it's brought down some medical error. But it's really chipping away at a problem that is vast. And it's just a huge problem. So are these figures reliable? Well, Lucian Leap, the doctor who served on the committee that wrote To Err is Human, he says, yep, our committee knew at the time that we did that report that the numbers were low. So this is scary stuff. And how can it happen? The system is fractured. You're sitting in a hospital bed. You may have dozens of people touching you, touching your case in a single day. Some who come to your bedside, some reading your reports. There's miscommunication. There's a lab result misread. There's a nurse that comes in to give you your meds, and then she gets called out to a big emergency, a pileup, a car pileup, and accidents in the ER. And the dose of medicine is skipped because the handoff didn't happen properly. Handoffs, shift changes. These are where the gaps and glitches in care can occur. Even with the best providers and the best hospitals, the most committed and wonderful people, we're only human, and we all make mistakes. But that is a very frightening thing. And if you knew what physicians, what our professionals are up against in medical care, you might be surprised they get it right as often as they do. Consider this. There's nearly 22,000 different diagnostic codes published by the World Health Organization. PubMed publishes 500,000 new studies every year. A doctor would have to read almost 13,000 studies every night after work just to keep up. You can see this is completely not feasible. Physicians are exhausted. Their lives have been kind of turned upside down by a lot of the mandates and the changes that are happening. The reimbursements are shrinking. They have less time with patients. Do you know how long it takes for a physician to interrupt a patient who's been asked to describe how they're feeling and what their symptoms are? Anybody know? 18 seconds. Yeah, and there's a movement afoot. It's called Give Me My 36 Seconds. Just give me my double of my 18 seconds before I'm interrupted. And again, this is just a product of how the system has been set up. With less reimbursements, you need to see more patients. So they're on a hamster wheel as well. And then there's nurses. Nurses, angels on earth, as far as I'm concerned. Caring for patients, battling politics, egos. A lot of them have to lug around this big cow of a portable computer from one patient room to the next, cleaning up messes, wiping tears, holding hands, and making the unbearable bearable. And then there are hospital-acquired infections. I had been a medical reporter toward the end of my time in television, and even I had no idea about the scope and the reality of hospital-acquired infections. That was until my own father went in the hospital in August of 2005. And it's what started me on the path of patient engagement. I have 3 brothers, but I was my dad's only daughter. And he was 75 years old at the time that he got up to use the bathroom one night and fell down the stairs and fractured a vertebra in his neck. And he was taken to the hospital where they had a surgery. Performed a surgery on him that was, again, one of those medical miracles. They fused the vertebrae in his neck, and he was going to be fine. Or so we thought. Because 2 days after surgery, my mom was talking to him, and he suddenly grew very cold and clammy. And she alerted the nurses something's wrong. And they whisked him into the OR, and they told us that his intestines had burst. And they were able to cut out a couple of feet of his colon, clean out the spilled contents, put in a colostomy bag, and save him. He had 11 IVs in him for the next week or so in the intensive care unit battling sepsis. But he survived. And they actually came home for a short time. So the doctors couldn't or wouldn't answer our questions. How can a fractured neck lead to burst intestines? How can this possibly happen? And they really didn't have any answers for us at that time. But there I was by his bedside for most of the next 6 months as this cascade of challenges and complications and infections ensued. And then there were these indignities that are just part of the system, I suppose. But his hearing aids were left on that bed table that's got, the water pitcher, the dinner tray, the phone, and everything on it. His hearing aids got water spilled on them, and they were ruined. So you can imagine what happened is I'd put notes up everywhere, and I'd tell anybody that came in, please speak up to my dad. And the notes, his room kept getting changed, and the notes got lost. Or people didn't see them. For whatever reason, my dad stopped answering. He would just nod. Very proud man, and it was a sad thing to see because it was eroding his dignity. And in a place where, he'd always been a very, very private and conservative man, there was not an ounce of privacy around his body anymore. And that's a hard thing to have your family there when your whole spirit is eroded in that way. So my father's body withered away from 175 pounds to 137. And he was tough. He was a stubborn Dutchman. He had MRSA, VRE, a case of shingles, which is a cousin to the chicken pox that emerges out of, under stress. It was very painful, and C. Diff. And he got through them all somehow. But 6 months after that fall down the stairs, it was February 10th, 2006, and I saw my dad that day, and he was in a good mood. He said, he'd gained some strength, and he was looking forward to coming home and driving a car again. That's the thing he wanted more than anything. And I said to myself, I think this is finally over, and he can come home. But that next night, the nurses checking on him in the middle of the night found him barely breathing. And they rushed him into intensive care again, and they called us, and my mom and my brother and I drove in there and called my brothers that live out of state, and there was no hope for my dad at that point. The cause of death was sepsis after we agreed as a family to take him off life support. So, we buried my dad, and we moved on as a family. But in the months that followed, I learned about hospital infections and that they kill 99,000 people a year. And I finally understood about C. diff. I did some research on it. One of the infections that the nurses told us were common in hospitals. And I don't know if you know the disease process of this infection, but it's pretty nasty. What happens is that when you get an antibiotic to kill off, my dad had a slight fever when he first went in the hospital, was given an antibiotic to bring the fever down. It kills off the good bacteria in your gut, which is one reason we've got to be really careful about using antibiotics. Without those good bacteria keeping balance, the C. diff bacteria thrives, and it multiplies, and it releases toxins and gases to the point where it can explode the intestines. And that's what happened to my dad. And not only that, it can be chronic. You keep giving infections to knock down this flare-up, rather antibiotics to knock down the flare-up, and it just continues this cycle. So it's not surprising when you look back that a recurrence caused his colon to rupture again. So what do you do with this information? Well, I've been a reporter my whole life, and it just seemed a logical step. I said, I have to help people understand. Knowledge is power. What can I do to help get this knowledge out there? So I began to work on a couple of patient safety laws. I worked with a bunch of quality improvement groups all over the country. I've been to a lot of conferences. I've read a lot of studies. And I've been at a lot of meetings. But I'm a person who has to do things. So I wrote a book. I created a device for patients so that their hearing aids won't get lost or ruined, and so that they can communicate better with their care teams. And I spend a crazy amount of time talking about patient engagement. Just ask my family. And by the way, patient engagement has to be just about the sexiest topic to bring up at a dinner party. Just watch their faces. But I am impatient. I'm an impatient patient. I'm impatient for real change for patients. And then one day, a year and a half ago, I needed all of it. I needed every little thing I'd learned and done in all my years of patient advocacy since my father died. Because that young woman, Jess, that I told you about, who'd hiked the Appalachian Trail and ended up with Guillain-Barré syndrome, Jess is my daughter. I am her mom. And watching my baby girl, who is one of the strongest and most positive people I know, lose her ability to walk and smile and swallow, fearing where this story could end up, was the most terrifying experience of my life. Gazing at her in that hospital bed, scared as I was also so grateful every day that I knew what I knew, and that I'd learned so much about what can happen if we don't pay attention every moment. I know how quickly things can go wrong, so I kept an eagle eye on her care. I was at the top of my game, and my paying attention and the team knowing that I was with them upped their game as well. And we really were a beautifully functioning team. I knew there were things out of my control and out of their control too. And maybe her remarkable recovery, which a local news reporter, as I said, called a miracle, would have been exactly the same without my engagement. We will never know that. But it sure was good to know, to feel as if I'd prepared for this. At the moment that I took that picture of Jess triumphant on her bike, you can imagine I could barely see. I was a teary mess, understanding what Jess and what our family had escaped. Now, Jess has since moved out to San Francisco, her dream city. She has a good job and a nice boyfriend. Isn't it wonderful that we can all move on as a family? Except I couldn't stop thinking about the other moms and dads who love their daughter as much as I love mine. Don't they deserve to know what I know? To have the knowledge, skills, and tools to work effectively with their care teams, to have the best possible outcome? Well, for me, this was a tipping point. Because though medical organizations and the government all talk about patient and family engagement and patient-centered care, too many initiatives, policies, and programs and publications continue to evolve without meaningful input from patients and families. The ones leading the healthcare tango, they get virtually all the training and all the support, but not their partners, the ones with the most skin in the game. Why is that? Why do the vast number of advisory boards and committees talk about patients without them in the room? Well, what you hear a lot from providers is this: we can't find any patients. Patients won't understand this. Well, we brought patients into the room and they weren't too intimidated to speak up. They didn't really add anything. We brought patients in and they had one story. There wasn't a lot we could learn from that. So it really didn't add so much. Or we brought a patient in to speak with us and they were angry and they were bitter. And it was hugely unhelpful, was not constructive. These are things you hear a lot. So providers doubt that patients have the knowledge, the consistency of values and a capacity to share that, and the availability. And while some patients are super engaged and ready, others are like, yeah, I might want to help out if I was asked, but where do I start? How do I do that? Or now that I'm here, what do I do? How can I have impact? Well, if nobody else was going to put this puzzle together, I figured that we patient advocates would have to. And we, being my friend and colleague, Diane Stallenwerk, and I, former VP at the National Quality Forum, who's had her own patient experiences and frustrations, formed the Patient Voice Institute, or PVI for short. Our aim is simple: to democratize healthcare, to give every patient a voice, and integrate the patient voice fully and functionally into the healthcare ecosystem. And we just launched in May, but we have ambitious goals: building patient and consumer market power to drive quality improvement by offering that TripAdvisor for the patient experience, with comments published on the website, all of it completely transparent, so Erica's and Jess's and everybody's experiences can be shared and compared. Embracing patients at every level of activation, acting as a hub for existing resources, and ensuring that articulate, compelling patient speakers, panelists, and advisors can be easily found and engaged by those organizations that sincerely want them, while also training the patients and consumers needed to advise nearly 150,000 hospitals, medical facilities, and health agencies in this country, and intriguing and enticing people from all demographics, literacy levels, and culture to activate and engage as patients. We have to let them speak in their own language literally, and we need to make our outreach and invitation so interesting that people on their own will tell two friends, and so on. Let the wisdom of the crowd change the culture. Now, PVI has a phenomenal group of senior advisors, all of whom are strong and successful patient voices around the country. You may recognize Regina Holliday if you were here last year. Other wonderful people. And our broader advisory group from PCORI and Leapfrog, the Beryl Institute, AARP, and others, all sharing this vision. We're giving patients and families tools, free tools to bridge the bed rail, a free patient passport, we're going to be talking about that in a later session, and surgical checklists, among other things. Our common language with providers is the research-based patient voice principles, compassionate human interactions, safety and continuity, access to needed information. You might think of this as the triple aim for patients. The hope is that when we're all on the same page about what really matters to patients, we can forge new alliances, build better teams, and inspire new success stories. 5 or 10 or 20 years from now, when the dynamics of value-based purchasing, meaningful use, ACOs, and aging boomers entering their years of highest healthcare need have all shaken out and created a new reality, a different breed of healthcare leader will emerge. People who've incorporated all the things that we've talked about here today, who think that it's inhumane that we waste billions of dollars in a system where some people forego medications so that they can put food on the table for their children, who know that good health care doesn't exist without human touch and a genuine caring for each other. Like Dr. King, whose birthday we observed recently, I have a dream that you will become the champions of this change. That through kindness, listening, not accepting bad behavior, modeling the right behaviors, encouraging patients to share their stories, and sharing yours, in 1,000 ways, big and small, that you will help foster a system that's holistic, functional, affordable, and responsive. With social change like civil rights and women's rights, history will look back on today's healthcare and say, wow, yeah, it used to be like that. What is this picture? Anybody know who this woman is? This is Catherine Switzer, who was the first woman to run the Boston Marathon in 1967. The men all around her are race officials. They're trying to pull her off the course. She'd signed up with her first initial and last name, and they were not happy when they saw her there. And they were saying that women can't run that far. 32 years later, remember this picture? Went around the world on the cover of Sports Illustrated. Brandi Chastain, when the women's soccer team won the World Cup. Now, in the 30 years, the 3 decades, between when that first picture was taken and the second picture, you can imagine that there were hundreds, if not thousands, of protests, rulings, progress, setbacks. Handbooks got rewritten, locker rooms rebuilt. No doubt there was a lot of muttering in some private quarters about those damn girls. They're ruining athletics for all of us. But in any social movement, gaining respect and parity takes legions of organizations, leaders, and landmarks, each an incremental step that builds on what's gone before. Lots of foot soldiers are needed. Whether it's through PVI or some other organization or a bunch of us, a big change is in process as patients become viable partners in healthcare reform. In the face of big headwinds and pushback from special interests and the seeming impossibility of the task, we need your passion, your commitment, and your best. You can be a hero in this story by helping patients and help yourself get from there to there. The alternative is, to borrow from another favorite quote, to find ourselves beautifully equipped to deal with a world that no longer exists. Thank you.
Thank you, Pat, for your moving story and helpful information and getting us in the right direction. We don't really have time for questions from the podium, but I'm sure she would enjoy speaking with some of you in the next few minutes before our next session. So you've got 15 minutes for break, and then we'll go come back in here at 9:30 to hear Lee Ace. So enjoy your break.
Fantastic.